Well, welcome back to session 5 of Rhythm Interventions Online 2022. This is a presentation and discussion session which will focus on the latest advances in PFA by Dr. Vivek Reddy. I'm delighted again to be joined by our panel, Dr. Andreas Metzner and Dr. Daniel Scher. But now I'll hand over to Dr. Reddy to take us through his presentation. Vivek.
Thanks so much, Devi. Hopefully you guys can hear and see everything okay. So my goal here is to talk about the latest advances in pulse field ablation. And before getting started, please note that I do have a number of disclosures. Many of the technologies that I'll be discussing do not have regulatory approval. In fact, most technologies don't have regulatory approval. So let's get started. Why excitement? Why is there excitement about pulse field ablation? I think you can see that in this preclinical study. What you're looking at here is the inferior vena cava, and there you have the esophagus with the balloon catheter shifting the esophagus up against the IVC. And there's the pulse field ablation catheter, and then for control, we have an RF ablation catheter in other animals. And here's what you see 30 days later after PFA. If you look in the pulse field animals, basically you see no lesions on the esophagus or the inferior vena cava. And as a comparator, if you look at the RF animals with thermal ablation, you have damage in all of the animals. And in fact, in this one, there was a fissureless connection. And then the clinical correlate. This is work from Hubert-Cochet and Piaget. And what you're looking at is a non-randomized comparison between thermal ablation, cryo or RF, versus pulse field on the right. Notice that the atrial tissue is enhanced because it's ablated with all three technologies. That's what you expect. That's what you want. But what's remarkable is that unlike with pulse field ablation, with cryo or RF ablation, in about half the patients, you see ablation that is enhancement of the esophagus, where, again, you don't see that with pulse field. And I think this graphically, visually shows you why PF is exciting to many people. What are the technologies? Well, the first one that was used in patients is the pentaspline catheter that can be used as shown here. There are a number of other catheters, a similar sort of basket-like strategy. There are also curvilinear catheters, a sphere balloon type catheter, a catheter that does cryo and PF. And then, of course, there are the focal catheters. Some of these just standard catheters or other designs that can deliver RF or PF in a different fashion. Now, of these, 2 of them have CE mark approval, the pentaspline catheter and this one focal ablation technology. And 4 of them, as shown here, are in FDA clinical trials. And a number more will be in clinical trials this coming year. I think one of the important issues to remember is that PFA1 does not equal PFA2. There's a number of different parameters, including catheter design and electrode configuration and a waveform that really differentiates this. So any data you get from PFA1 approach really has to be studied almost completely with PFA2 or 3 or 4, et cetera. Let's look at this is again with the initial pentaspline catheter, and there you see again the delayed enhanced ablated tissue around the pulmonary veins. And this from Hubert-Cochet and Piaget. From this initial first-in-human data, what we saw with a number of different studies is we were able to get good isolation. What about durability? Now, before I show you the durability data, I want to, again, emphasize 2 points. First, all of the waveforms that we studied were highly durable in preclinical studies. And number 2, all of these waveforms that I'm going to show you were 100% isolated at the end of the index procedure. But when we brought the patients back for second procedures, what we saw was that with the initial waveform, only half the veins were durably isolated. But with waveform evolution, this eventually increased to 96% of veins isolated, which translates to 84% of patients with all veins isolated. The other point I want to make is if you look at this 96% of veins isolated, you can see that whether or not we used ICE imaging had an important impact on durability. If we used ICE, it was 98%. If we didn't, it was 92%. The point I'm trying to make here is not that ICE is critical, though I certainly think it's very, very helpful, but rather that technique does matter. And I think this 96% shows you what's achievable, but you still have to make sure you follow the protocol in order to get that kind of durability. And the durability does translate to good clinical outcomes. These are the 1-year outcomes, and in red is using the optimized waveform at 85% at 1 year. In persistent patients, we had good durability of not just the PVIs, but also posterior wall ablation, as shown here. And again, this is a very small data set, only 25 patients, but the one-year outcomes look quite remarkable at 92% success. Now, we should note, this is being all these are being studied in large FDA trials. Advent is a randomized trial looking at paroxysmal patients. It finished enrollment and is now in follow-up. Advantage is a large FDA trial of persistent patients that will commence in a few months. And Beat AF is an ongoing European randomized trial that Piaget is leading, looking at both paroxysmal and persistent patients, and it's ongoing. So we will see some very large data sets, including randomized data, in the next year or so. What about in the real world? Well, this is a publication that just came out from Julian and Boris. They looked at those patients that came back for second procedures, and when they looked at the redo patients, what they saw was only 9% of the veins were reconnected. So that's, I think, quite good. Interestingly, it did matter which device they used. Those where they used the 31 millimeter device, they had better durability. But again, we have to be careful about these data because some of this may have been sort of learning related, and we have to see what randomized data look like. The other interesting point in their manuscript was that if you look at the area of reconnection, it tended to be on the left-sided ridge, as shown here. So I think this is emerging data, and overall it tells us that durability is being seen in the real world. What about safety? Well, this is the Manifest PF survey which we conducted at the first 24 centers that started pulse field ablation in Europe. In fact, Daniel and Andreas were two of the large centers that included patients. There was a total of 90 operators, over 1,700 patients. Acute PVI was quite good. And importantly, if you look at what we'll call the sort of the energy-specific adverse events, we didn't see any esophageal events, PV stenosis, or phrenic nerve paralysis. Though I should note there was a 0.4% rate of transient phrenic nerve paresis, so we need to continue to watch that. Now, what about sort of the general type of catheter-related complications? Well, there were a number of vascular complications, which certainly highlights, I think, the importance of being very careful with puncture, probably using ultrasound. There was also a 0.97% rate of pericardial effusion, not really related to PFA, but rather to the catheter manipulation, et cetera. And importantly, the rate of mortality was less than 1 in 1,000. And again, remember, this includes everyone's learning curve in the first 24 centers. I think it's quite remarkable. There was also one unusual event, which is a coronary spasm, and this has been published. And we got interested in this, and we wanted to ask the question, how often does spasm really occur with pulse field? So we decided to look at this in two ways. One is remote spasm, meaning if you ablate, let's say, the PVs or the posterior wall further away from where the coronaries are, do you see spasm? And the answer to that, by the way, is basically no. If you look here, during PV ablation or posterior wall ablation, there was absolutely no evidence of spasm. And again, we shot the coronaries with each of these lesions. On the other hand, if you look at that's what we call adjacent PFA, so here you see the pulse field catheter at the CT isthmus. During ablation, we shot the coronaries, and here we actually did see spasm. We saw severe spasm in 100% of the cases. What if we first pre-treat with nitroglycerin, either intracoronary or intravenous, and there we're able to completely abrogate the severe spasm, and there was only minimal spasm that was seen in a small number of patients. So our conclusion from this is that if you're ablating away from the coronaries, you don't have to worry about spasm. If you're ablating next to the coronaries, you will universally see spasm, though I should note in none of these cases did this cause any clinical phenomena, no ST elevation that we observed. So I think this is emerging data, and we need to understand better how best to manage the situation. In my own mind, I think it makes a lot of sense to give nitro before ablating next to a coronary. I think the exact dosing, these are things that still need to be worked out well. One last piece of data I just want to talk about. This is a paper that we have in Press looking at the effect of pulse field on the autonomic system. And we looked at this in three ways. Number one, we looked at heart rate. It's well described, and everyone knows after thermal ablation, whether RF or cryo, you tend to see an elevation in heart rate. In our experience, we saw an increase of 10 points at 3 months. But with pulse field ablation, there was no increase in heart rate, suggesting that the ganglia are not permanently affected. That's point number one. The second observation was looking at repetitiveness of the vagal responses. So when we did these procedures, you can see here a pulse train, and if you look here, you can actually see a little bit of a vagal response with a transient AV block. So what we asked is, with successive applications, how often do you see persistence of a vagal effect? Meaning, if you see it with the first lesion, over the subsequent 4 lesions that are delivered over the course of that vein ablation, do you continue to see vagal effect? And that's what we saw. We typically saw repetitiveness of the vagal effect, suggesting that the vagal effect is stimulation of the ganglia as opposed to ablation of the ganglia. And the final observation was directly looking at ganglia. So what we did was, first, we created a voltage, an electro-anatomical map, and identified the GPs by high-frequency stimulation. Then we did PV isolation with the pentaspline catheter, as usual fashion. Then we went back to electro-anatomical map, identify the low voltage area so that we could identify with each GPs, is it in the area of low voltage or is it outside? So then we could repeat the stimulation at those GPs that were inside the low voltage to determine whether or not they continued to exhibit the vagal response with repeated high frequency stimulation. Here's what we saw. 76% of the GPs were not ablated, those in the low voltage zone. In a few that were ablated, at least acutely, when the patients came back for remapping procedures, those actually had regained responsiveness. So ultimately, overall durable GP ablation is only about 8%. So with pulse field, largely we leave the GPs unablated, at least with this endocardial ablation technology. So last slide, I would argue that the initial data with pulse field is quite promising, with good procedural performance and good early safety, though we do have to recognize that there's little multi-center data, and it's I think fortunate there are multiple FDA trials with careful follow-up that are being conducted, as well as good European studies that are ongoing. There are a number of innovative PFA catheters in development, and I again want to emphasize that each device needs to prove its own safety as well as effectiveness, and particularly durability. My own feeling is that remapping studies are necessary with all these technologies. Ideally, they're protocol-driven remapping, meaning you do a remap no matter what at 2, 3, 4 months, whatever. But minimally, I think patients that come back for clinically driven second procedures, we need to understand what the PV reconnection rates are. Perhaps it's an overestimate of the true reconnection rate, because these are patients who have clinical recurrences, but it gives us an important hint as to what's happening. Finally, of course, we need to continue to learn about PFA. I told you about the minimal effect on the pericardiac ganglia. What does that mean? Is that a good thing or is that a bad thing? And there are reasons to look at this both ways. We have good safety with 1,700 patients treated. What happens after we treat 10,000 patients? Are we going to see even rare safety events? I don't think so, but I could easily be wrong, and I think we need to really understand this empirically. And certainly, this is outside the scope of this presentation, but there's a lot of potential promise of pulse field for ventricular ablation. I think this is an area of active research. And finally, I just want to put a plug in for Virtual EP Connect, where we talk about these various things like pulse field. So please do join us on virtualepconnect.com. Thank you very much.
Thank you, Vivek. That was a great overview of pulse field, and for me, it's pulse field is just available as part of clinical trials, and it's just hard to see why I would want to choose another technology to do AF ablation at this point. So I have to say I'm jealous of Daniel and Andreas, who have access to it on a daily basis. And what are your thoughts on technologies that we have? Would you consider any other technology at this point for AF ablation? Andreas, how about you?
So maybe I can start. Thanks again for this great presentation, Vivek. It's really amazing data. We also started with PFA about 1.5 years ago, did maybe 200 cases. And I can also only state it seems to be very effective, very safe, and also very reproducible. However, I have 2 questions finally. First is, Vivek, you also presented the follow-up data of the Manifest registry finally. And in paroxysmal AF, the success rate after 1 year was, I think, 85, 86%. So what does it mean? Does it mean that we still have reconduction gaps and we cannot achieve more? Or is maybe 86 the maximum we can achieve for durable PVI? What do you think? And the second question is, what we observed in our cohort, we have quite some patients, or not quite some, but we have some patients coming back with recurrence of AF after previous PFA ablation. And we have a tendency that we have less reconduction gaps in the later cases as compared to the very first ones. So I think there's also, although it's an easy technology finally, there must be some kind of learning curve. Or what do you think?
No, look, I don't think there's a technology that doesn't have a learning curve, right? And it's just a question of how quickly we get to it. I completely agree that there will be some learning curve. I do anticipate that there will be some reconnections, and that we'll get better at that with operator experience and sort of whole community experience. But I also do believe that they're non-PV triggers. And what is the exact rate of non-PV triggers? I mean, part of it depends on the population, right? If you take earlier stage patients, you'll probably have fewer non-PV triggers. If you take patients who are a little further along in their disease process, diabetes, hypertension, whatever, you find a slightly higher rate of non-PV triggers. So I do think the whole issue of non-PV triggers is going to be one that we as a community are going to be dealing with more and more, because when these patients come back for redo procedures, and there will be a lot of redos, as you know, because it's going to be a lot of dos, we're going to be increasingly finding all the veins isolated, and then we have to come up with the best way of eliciting these non-PV triggers and then rapidly mapping them, because as you know, you only get that first beat to map. So yeah, I think both issues are important issues.
So if I can jump in both with a comment and a question, Debbie. So the reason we're proud and very happy to be part of the Manifest Consortium is that I think it really represents that learning curve that both my colleagues were talking about, and still we as a consortium come up with an about 80% success rate. So it's the same for us. We did about 200 cases so far with 2 systems, predominantly with the FARAPulse system. There is a learning curve, but there are tricks and tips and tricks that you find out pretty quickly. And we do have a much better success rate now than we had in, let's say, the first 50 cases. Now, having said that, I have 2 questions for Vivek, and that is question number 1. I think we all learned that contact is important. We know, that the catheter needs to be in contact with the tissues, but question number 1 would be, I certainly don't know if we need real contact force, if contact force plays a role, and I was wondering if Vivek could give us some insight to that. And question number two, we see that most companies, most industry partners are currently designing 3 types of catheters for PFA. There is a linear catheter, then there is a small basket catheter, and maybe a big single shot device. So maybe as a second question, Vivek could take a look into the crystal ball, and like for the atrial ablation, now just focusing on the atrial ablation, which of the 3 he thinks we're going to predominantly end up working with, like in 2 to 5 years?
Yeah, no, I mean, these are great points. Let's just take the second one first. I think that, as oftentimes happens, there'll be multiple ways to approach the problem, right? I think all of those approaches, whether it's focal, basket, or let's say a single shot type approach, or some regional approach that you use with the mapping system, I think they all are reasonable and will work well. My own feeling is what happens depends really on what the data is going to show on the success rate with PVI alone, or PVI plus posterior wall alone, in the paroxysmal and precision populations. Because if those success rates are in the 80% range, it's going to be very seductive, let's say, appropriately seductive, to simply just do that, because you could do that very, very quickly, not worrying about electron-anatomical mapping and all of that. On the other hand, if the success rate really is less, then I think it makes sense to consider doing more and identifying the right things to do in the first procedure. But if you can get in and out in 30 minutes without much time mapping, and just get and treat the patient, maybe send them home the same day, again, I don't think you will be getting away from that. The second question, which was the first question, basically you're asking about the contact force. My own feeling is contact sensing is really useful to tell you when you're in proximity to the tissue. And so for focal catheters, I think we as a community are used to and will continue to want some sort of strategy to know that we're touching tissue. Whether it's force versus other, type ways of sensing, I'm sort of agnostic to that. I think for single shot catheters, I don't think that matters as much, Daniel. I think that understanding where you deposited the pulsed field probably matters more. So for example, with the pentaspline catheter and other technologies, as you know, the companies are going to be sort of showing us the field of where that splotch that we delivered. And so then you could look at that and concatenate all of these to make sure you have a circumferential field that's ablated. And I think strategies like that may allow us to minimize the number of lesions, though. I mean, honestly, the procedure is like 20 minutes now, so I don't know how much shorter it can be. But there is one last point I want to make. The downside of all of this is right as soon as you say the words electron-anatomical mapping, then the issue of how you do anesthesia starts becoming an important one, I think, because if you have, with pulse field, you can have coughing and other issues that can occur, and they can vary between patients, as you know. And if you have a lot of that and the patient's moving, then suddenly, what does that mean? We're going to have to use general anesthesia in all of these patients, and then that changes how you think about the workflow. So I think the challenge to industry is how do you allow us to get all the stuff we want, electron-anatomical mapping, blah blah blah, and yet allow us to do it in a way that's efficient for the lab, for the system.
Vivek, the two things that stood out definitely is one is spasm, because we talk about PF being extremely safe, and you demonstrated that there is concern with spasm. So I was wondering if you could elaborate on your thoughts about this being not just a factor with PF alone, but maybe RF too, and we just don't consider it as much. Or do you consider it during your RF ablations as well?
I don't really consider it. And I think I should be considering it probably more. I don't think we need good comparative studies between PF and RF to understand the difference. My own feeling is that it probably is going to occur with thermal ablation. I don't know if it's going to occur as frequently, but we have to see. I think, again, I do want to emphasize that this is subclinical spasm, everything that we've seen. But look, this was prompted by, our whole study, it was prompted by the clinical spasm that, Melanie, Stefan Willems, their group reported in that case report. So that was a patient who had ST elevation and it was a real event. So I think the question is going to be, how often does spasm happen? And depending on that number, does it make sense to pre-treat with nitro in all the patients? My own feeling is I would rather pre-treat than even have a 1 in 200 spasm, clinical spasm, that is, because most of these are subclinical. But I think this is something that needs to be worked out. I'd love to hear Daniel and Andreas' thoughts on this, because how do you guys look at this? Understanding that there are still some unknowns.
Yeah, as mentioned, we have quite some experience for the system now. So far, we never had any clinical spasm or whatever. So in none of the cases we had ST elevation or whatever. However, after I've seen your study and the publication of your study, it seems to be quite interesting, seems important, and think about how to deal with that issue. But as mentioned, when using it for PVI only, and that's what we did so far, I never experienced any clinical situation with ST elevation or whatever. And so far, I think for pure PVI, I guess the incidence of something like this will be very low.
So just to give my 2 cents, look, I first want to put this into a greater perspective, and that is, in our experience, and I think also in the entire manifest experience, the safety profile has been excellent, right? So, and then of course, when it gets to doing ablations with PFA, let's say on the mitral isthmus, there have been reports, and you have beautifully demonstrated the mechanism behind it of coronary spasm. To answer your question directly, yes, if I would have to apply PF energy, let's say the mitral isthmus, which we have done in a number of cases before we were aware of the coronary spasm issue. Now that we are aware of it, I would pre-treat patients with nitro because, as you said, it's, a preventive strategy is always a better one, even if the risk is low. Having said that, since the reports came out, we for now stopped applying PF energy at the mitral isthmus, for example, and simply apply it to the PVs and the posterior wall and wait for more data to come out.
And again, I just want to underscore, because I don't want to overstate this. When we looked during PV ablation or posterior wall ablation, we didn't see even subclinical spasm. It's only when you're ablating literally next to the coronary that we see the subclinical spasm. So, yeah.
And Vivek, about the GPs, do you think there's going to be a role for extra cardiac work with things like denervation that will stand out now, since we're showing that the GPs are not as much affected with PF?
Yeah, it's a good question. Look, what do we know? We know the GPs are largely non-ablated. We know that we're getting good clinical success, at least at 1 year, let's say, and we even have data out to 3 years from the first human studies. So then the question becomes, so what's the good? The good is now we're not seeing that 10 and 20 point elevation in heart rate. And as we know, there are the occasional patients that have even higher elevations in heart rates that can be quite problematic. We're not seeing that. The downside, potential downside, is does this mean we're not getting the potential benefit of GP ablation for, let's say, non-PV triggers and other stuff? We don't see clinical evidence of that, but really the study I think that needs to get done now is if you do PFA-based PVI in a bunch of patients, and in half the patients randomly, you additionally ablate the GPs with thermal ablation, do you improve your success further? And I think that's, an interesting question that, needs to be addressed. I think what you're also suggesting is other things, renal denervation or other cutaneous stimulation or whatever. Will these things further improve or in these pulse field patients? And I think, I don't think there's going to be a dearth of questions that we have to study going forward.
Well, unfortunately, this is all we have time for this session, and it's been a great discussion. I really would like to thank you, Vivek, for giving such an excellent presentation and taking all of our questions, and the panelists as well. Andreas and Daniel, thank you again for participating in this session and the previous session. So this brings us to the close and the end of Rio 2022 Day 1. But before we leave you, let's join my good friend and course director, Richard Schilling, for a summary of today's proceedings. Thank you and goodbye.
Fantastic. Thanks, Devi, and thanks to all of you for an amazing day. I'd like to thank everyone for attending Rio on Day 1. There's been plenty of highlights. We've had some great live cases from some leading centres. We've had pulse field ablation using sedation and single shot pulmonary vein isolation using the novel RF balloon from Boris and Julian and team in Frankfurt. And we've had pulse field and radiofrequency ablation using novel focal lattice tip catheters with zero fluoroscopy from Devi in Arkansas. And then the convergent procedure and left atrial appendage management from John Yap and Saeed Hassan at Barts in London. And of course, some great presentations on the latest advances in PFA from Vivek Reddy. More of the same tomorrow. So live cases from me and Ross Hunter in London and Claudio Tondo in Milan. And we'd like to thank our industry partners, the headline partners, Boston Scientific and Medtronic, our partners, Abbott and AtriCure, and our supporting partners, Biosense Webster, EBR Systems, and Volta Medical. So wherever you are in the world, good night, and join us tomorrow where the focus will be mapping and imaging live from 3 p.m. Central European Time or 9 a.m. Eastern Time. We look forward to seeing you then. Good night.